thyroid disorders are going to be divided into hyper and hypothyroidism. We're going to start with congenital hypothyroidism. Most of these are from thyroid dysgenesis. It's very common, occurring in about 1 in every 4,000 live births, a little more common in females. Congenital hypothyroidism we've kind of alluded to earlier with some findings in the neonate. At birth they have normal height and length and weight. Look for prolonged jaundice. When we talked about jaundice in the newborn, that's one of the causes of prolonged jaundice was going to be hypothyroidism. These patients also tend to be somewhat floppy as time goes on. They have a large tongue. The mouth tends to stay open. They will have umbilical hernias. They can have mottled skin. They can have sparse hair. They can have feeding problems and apnea, and also constipation. So you have to put these all together. One of the other things that is seen is developmental delays. It's very important to pick these up early. The sooner you pick them up, then you're going to decrease the risk of developmental delays and mental retardation. The babies are floppy or have hypotonia, and it's very commonly you'll see that they have a large fontanelle, particularly a large posterior fontanelle. The posterior fontanelle may be closed at birth, usually closes by 4 to 5 months of age. But if it's open and it's big, and if the anterior fontanelle is also big, think of 2 things: hydrocephalus, and also think of congenital hypothyroidism. And with congenital hypothyroidism, put together these other findings we've described, and that should lead you along that way. And since it's 1 in 4,000 births, that's a very good reason to do newborn screening. Newborn screening measures the T4. If that is low, then you go on and measure TSH. The test that you're going to draw is T4 and free T4. Those are better than the T3, and those will be low, and the TSH will be elevated. That gives you the diagnosis of hypothyroidism. It doesn't matter if it's congenital or acquired. You're going to order the same tests. You're going to have the same results. The management of both congenital and acquired hypothyroidism is going to be supplying thyroxine. So here's a baby with congenital hypothyroidism. Again, kind of floppy, sluggish. The tongue is sticking out just a little bit, and there's an umbilical hernia. Acquired hypothyroidism, the most common cause is Hashimoto's thyroiditis. Thyroiditis and hyperthyroidism many times become hypothyroidism simply because it's easier to manage hypo than it is to manage hyper. It's also seen in Down syndrome. We kind of mentioned that already. Patients with Down syndrome have a higher risk for hypothyroidism, and it's associated with a couple of other syndromes. The first thing that you're going to see with acquired hypothyroidism is a deceleration of growth. When we talk about congenital hypothyroidism, we worry about mental retardation. You want to pick it up early. But with acquired hypothyroidism, it's not so much school problems as it's going to be that they start going across the growth curve. So they're going to slow down in growth velocity, and you need to be very cognizant of that. Later on, you're going to see the myxedema and osseous maturation and all the other problems. On exam, you will notice a very firm, enlarged thyroid. It's non-tender, and it's kind of just diffusely enlarged. The diagnosis is made the same way. You're going to order your T4, free T4, and TSH. The T4 will be low, the TSH will be high, and the treatment is also going to be replacement with thyroxine. You can follow their increase in height. You can see it's dramatic. Once you start them on the thyroid hormone replacement, you can see that their height starts to come back up. The opposite is hyperthyroidism, and almost all patients with hyperthyroidism are Graves' disease. With Graves' disease, you will see that there's lots of lymphocytes infiltrated into the thyroid. They will also have just a diffuse lymphoid hyperplasia and thymic hyperplasia. One of the characteristics is going to be the big eyes. They will have emotional lability. That's one of the first signs you're going to see is emotional lability and motor hyperactivity. and this kind of leads them to have decreased school performance. You might be thinking that this child, oh my gosh, has attention deficit hyperactivity disorder. Well, it's part of the differential diagnosis, but certainly these patients can be cured without methylphenidate. They can be cured by taking certain other medications. These patients will have increased appetite, but they still lose weight. They can have episodes of flushing of the skin and tachycardia. Sometimes they'll complain of palpitations. So patients with runs of palpitations, you should worry about hyperthyroidism in addition to other catecholamine-producing substances. Some patients will present in what's known as a thyroid crisis or thyroid storm, where they are extremely tachycardic and palpitations, hypertensive, very agitated. You will sometimes see hyperthyroidism in the newborn. If the mom had hyperthyroidism, sometimes the babies will have that. These babies will show up sometimes at around a couple of weeks of age, 2 to 3 weeks, and they haven't regained their birth weight. And when you examine them, their heart rates are about 190, 200, 220. Their eyes will be bulging out just like Graves' disease. These babies sometimes it's a transient hyperthyroidism, but they still need the same amount of treatment as Graves' disease. On exam, you can palpate the enlarged thyroid, and you can see exophthalmos. Again, the same test that you do for hypothyroidism, you do for hyperthyroidism, except the values are reversed. In this case, T4 and T3 and the free T4 will be elevated, but the TSH will be decreased. The treatment is to put them on propylthiouracil or methimazole. Beta blockers are good for a crisis and the acute symptoms. Again, it's always easier to treat hypothyroidism than hyperthyroidism, so many times you want to either chemically or radiologically ablate them, and then it's easier to treat them with thyroxine. This is a woman who has goiter. You can see right here in the neck. It comes out both sides. Remember that the thyroid kind of has wings to it. It comes out this way, and you can see that she has exophthalmos. And here is someone laying down, and again, the goiter extends on both sides of the neck.